and rectum. The extent of the musculoskeletal examination depends upon the patient's condition and symptoms. A fairly detailed examination is presented here. Ask the patient to tell you of any tenderness and be alert to facial signs of distress as well. Begin the musculoskeletal examination by palpating the temporomandibular joint. Ask the patient to open his mouth. Feel and listen for crepitation. Observe for any limitation of the range of motion of the jaw. Inspect the neck for symmetry, deformities, or abnormal posture. Palpate for tenderness of the cervical spine, the paravertebral muscles, and trapezii. Test range of motion of the neck by asking the patient to flex his chin to his chest, rotate his chin toward each shoulder, bend laterally toward the shoulder, and extend his head backward. These movements should be performed with ease. Test range of motion of the hands and wrists. Ask the patient to spread and close his fingers. Make a fist. Flex and extend his wrists, and to abduct and adduct them. Inspect the hands and wrists, noting any swelling, redness, nodules, deformity, or muscular atrophy. Here, none are seen. Palpate the medial and lateral aspects of each interphalangeal joint between your thumb and index finger. Note any swelling, bogginess, bony enlargement, or tenderness. With your thumbs, palpate the metacarpophalangeal joints of each hand, just distal to and on each side of the knuckle. Palpate each wrist joint, with your thumbs on the dorsum of the wrist, your fingers beneath it. Test the range of motion of the patient's elbows. Ask him to bend and straighten them. With his arms at his sides and elbows flexed to 90 degrees, ask him to turn his palms up and down. Note the ease and range of movement. Here is the right elbow seen from behind. Assessment of the elbow joint includes the ulna, its olecranon process, the overlying olecranon bursa, and the medial and lateral epicondyles of the humerus. The synovial membrane is most accessible between the olecranon and the epicondyles. However, neither bursa nor synovium is normally palpable. The sensitive ulnar nerve lies between the olecranon process and the medial epicondyle. Support the patient's forearm so that the elbow is partially flexed. Inspect and palpate each elbow, including the extensor surface of the ulna and the olecranon process, noting any nodules, swelling, or tenderness. Palpate the groove on either side of the olecranon for tenderness or swelling. Also check the lateral epicondyle for tenderness. Assessment of the shoulder requires awareness of landmarks and articulations. The manubrium articulates with the clavicle at the sternoclavicular joint. The clavicle articulates with the scapula at the acromioclavicular joint. The scapular portion of this joint is formed by the acromion process, a continuation of the spine of the scapula. Below and just medial to the acromioclavicular joint is the bony coracoid process. The coracoid process is also part of the scapula and is readily palpable anteriorly. Below the acromioclavicular joint and a little lateral to it is the head of the humerus with its greater and lesser tubercles. One head of the biceps tendon lies in a groove which separates the tubercles. The clinically important subacromial bursa lies above, lateral, and anterior to the head of the humerus, deep to the deltoid muscle. Normally, this bursa cannot be felt. Assess the range of motion of the shoulder and environs as the patient raises both arms to a vertical position, places his hands behind his neck with elbows out, and places his hands behind the small of his back. Cup your hand over the shoulder to note any crepitation.
Left arm behind your head again.
Observe and palpate the scapulae and related muscles posteriorly. The muscles should be symmetrical without atrophy or spasm. Inspect the anterior shoulder and shoulder girdle for symmetry, noting any atrophy, swelling, or deformity. This patient has an enlarged medial end of his right clavicle. Palpate for tenderness in the sternoclavicular joint, the acromioclavicular joint, and the shoulder itself, including the biceps groove and the greater tubercle of the humerus. With the patient lying down, inspect the ankles and feet. Note any deformity, nodules, or swelling, any calluses or corns. Palpate the anterior surface of the ankle joint, noting any bogginess, swelling, or tenderness. Feel along the Achilles tendon for nodules. Test for tenderness of the metatarsophalangeal joints. Each joint may be further evaluated by palpating the metatarsal head in the sole of the foot and compressing the joint between thumb and finger. To check the range of motion in ankles and feet, dorsiflex and plantarflex the foot at the ankle. Then stabilize the ankle, grasp the heel, and evert and invert the foot at the subtalar joint. Now stabilize the heel, invert and evert the forefoot. Repeat on the opposite foot. Flex the toes on the metatarsophalangeal joints. There should be no limitation of movement. Accurate assessment of the knee requires an understanding of the joint anatomy. The knee joint is triarticular, with femoral and tibial condyles forming medial and lateral joints, and an anterior joint where the patella slides over the femur. The condyloid surfaces are enveloped in a sac that is lined with synovial membrane. The suprapatellar pouch is an extension of this sac. Inspect the knees, noting their alignment and any deformity. Note any atrophy of the quadriceps muscles or loss of the normal hollows around the patella. Palpate the area of the suprapatellar pouch on each side of the quadriceps, noting any thickening, fogginess, or tenderness. Compress the suprapatellar pouch. Palpate on each side of the patella, over the joint space itself, and near the femoral epicondyles. Identify any structural abnormalities, thickening, or edema. Again, the suprapatellar pouch on each side of the patella and over the joint space. If a small amount of fluid in the knee is suspected, look for a bulge sign. Milk the medial aspect of the knee firmly upward to displace any fluid. Next, press or tap the knee just behind the lateral margin of the patella. Watch for a bulge of returning fluid. None is seen here. Here, in another patient, we see a positive bulge sign. Ballot for a floating patella. Firmly grasp the thigh just above the knee with one hand, thus compressing the suprapatellar pouch. With the fingers of your other hand, push the patella sharply back against the femur. Feel for a tap against your finger, indicating fluid within the knee joint. To begin the assessment of hip mobility, rock each of the patient's legs back and forth while observing for any pain or limitation of movement. Then, ask the patient to bend his knee to his chest, pulling it firmly against his abdomen. Observe the degree of flexion at the hip and knee. The patient should be able to flex the knee and hip without difficulty, while the opposite thigh remains flat on the table. Place the patient's foot on the opposite patella. Pull the knee laterally to rotate the leg externally at the hip. Then rotate the hip internally by pulling the knee medially, the foot laterally. Repeat on the opposite leg. As you return the leg to rest, cup your hand over the knee to detect crepitation. With the patient standing, inspect the spinal profile, observing the normal concave cervical, convex thoracic, and concave lumbar curves. Inspect the spine for lateral curvature. There should be none. Note any deformities of the knees. Palpate any swellings in the popliteal spaces. Note any abnormalities, such as flat feet seen here. Palpate the spinous processes for tenderness. And the paravertebral muscles for tenderness and spasm. Check the range of motion of the spine. The spine should be symmetrical with full and easy range of motion. The normally concave lumbar curve should become convex as spinal flexion proceeds. To further assess range of motion, stabilize the patient's pelvis with your hands and ask the patient to bend sideways.
Now to the right. Right, straighten up. Now bend back toward me.
Bend backward.
Now twist around to the left.
And twist his shoulders one way, then the other.
And twist to the
This
right.
should be done with ease. With aging, you may see the effect of gravity on skin. Decreased muscle mass is often visible and palpable. Here, note the increased size of the hollows near the patella. Osteoporosis and disc degeneration result in decreased height and changes in the curvature of the spine. The head may be bent forward. Although there are additional special maneuvers for specific problems, this completes a fairly detailed musculoskeletal examination.
Thank you very much.
The patient's mental status is assessed during the history. Mental status may reflect specific abnormalities within the brain, but also depends on the patient's general health, personal experiences, relationships with others, and the environment in which he finds himself. Listen carefully. Are answers appropriate?
What's your name?
Are ideas expressed logically? Can the patient deal with abstract concepts?
Some answers to that.
Note articulation, pronunciation, and rhythm of speech. Assessment of mood, memory, and orientation was begun during the history and is continued throughout the examination.
Were you dazed in that accident?
A little bit disoriented.
Did you have seizures anytime?
No, sir.
None whatsoever.
There are 12 paired cranial nerves. The olfactory, or first cranial nerve, mediates the sense of smell. Be sure both nasal passages are patent. With one of the patient's nostrils occluded and his eyes closed, ask whether he smells something, and then to identify it. Mildly aromatic substances such as vanilla, cloves, soap, and coffee may be used. Differences in perception and identification between the two sides may be important.
Tell me what it is.
This is vanilla.
Okay, I'm going to do it again, but this time for the other. Smell again.
That is cloves.
Good. Open your eyes. That's pretty good.
For the optic, or second cranial nerve, two aspects of vision are tested: visual acuity and the visual fields. Acuity may be tested by asking the patient to read aloud the smallest print on a handheld eye card. If the patient uses reading glasses or contact lenses, he should wear them.
Read this line for me, right here.
374258
How about the next line?
937826.
That's good. Now I want you to switch your hands now. Cover your right eye and hold this in your left hand, just right about here. Now that's good. I want you to read this line again.
374258
Next line.
9378.
For screening purposes, visual fields are tested by confrontation. Ask him to cover one eye and to look into your eye directly opposite. Close your other eye so that your visual field is superimposed upon the patient's. Bring your wiggling finger or other small test object into his field of vision from 8 directions, equally dividing the full circle of the visual field. Ask the patient to tell you as soon as the object appears. Compare his field of vision with your own. Repeat with the other eye.
Left eye now.
Keep the object approximately midway between the patient's eye and your own, except in the temporal field. Here, you need to start somewhat behind the patient. A more subtle form of field defect can occur when the visual cortex is damaged, as in a stroke. To detect this, test for extinction by double stimuli testing. The patient should open both eyes. Wiggle your fingers in both temporal fields simultaneously. Ask the patient whether one or two fingers are moving. He should see both. Remember that you can also inspect the optic nerve itself by observing the optic disc directly. Two significant neurological abnormalities of the optic disc are papilledema and atrophy. In papilledema, the disc looks swollen and pink. Its margins are blurred. Its tiny vessels are engorged, and the physiological cup cannot be seen. In optic atrophy, the disc is white and the physiological cup is not evident. Eye movements are controlled by the oculomotor, trochlear, and abducens nerves, the third, fourth, and sixth cranial nerves. They are examined as a group. The third cranial nerve also constricts the pupil and raises the eyelid. Begin by examining the position of the upper eyelids with the patient looking directly at you. The eyelids should not obscure the pupils. Inspect the pupils. They should be round and approximately equal in size. Size should be appropriate to room light. Test the pupillary reaction to light by shining a light on each pupil in turn. Inspect both the direct and consensual reactions. Test the range of extraocular movements through the 6 cardinal fields of gaze by asking the patient to follow your finger. Pause during upward and lateral gaze to detect nystagmus. Inspect the parallel movement of the eyes and note any lid lag. Eyeball and eyelid should move simultaneously and smoothly. Test the pupillary reaction to accommodation. Ask the patient to follow your finger as you move it towards the bridge of his nose. Inspect the pupillary constriction and convergence of the eyes. If you have difficulty seeing pupillary constriction, darken the room and repeat the maneuver. The trigeminal, or fifth cranial nerve, mediates general sensation of the face and the corneal reflex. It supplies motor innervation to all the muscles of mastication. To test motor function, ask the patient to clench his teeth and then relax, while you palpate the temporal muscles and then the masseter muscles. The sensory portion of the trigeminal nerve has 3 divisions: the ophthalmic, maxillary, and mandibular. All 3 areas must be symmetrically tested. A test for pain is used. Show the patient how you will assess for pain.
This is dull. Now I want you to close your eyes.
Then test for pain sensation using the sharp end of a safety pin.
Sharp.
Are they both the same?
Yes, sir.
Good. How about this?
Sharp.
How about this?
Sharp.
Occasionally substitute the dull end.
What is it?
Ask the patient to distinguish between sharp and dull
Good.
and to tell you whether the sharp sensation is different in any area.
Are they both same?
Yes, they are.
And how about this?
It's dull.
Good. Open your eyes. That's good.
If an abnormality is found, confirm it by testing temperature sensitivity. First, demonstrate the test for the patient with his eyes open. Then, compare symmetrical areas with the patient's eyes closed.
Cold. Hot.
How about now?
Cold.
How about now?
Cold.
How about now?
Warm.
How about now?
Cold.
Good. Open your eyes.
Then, test for light touch using a wisp of cotton. After demonstrating the test, ask the patient to respond by saying, "Now," whenever you touch his skin.
Close your eyes. Tell me every time you feel it.
No. 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 No.
Good. Open your eyes.
To test the corneal reflex, use a cotton applicator. Make a fine wisp of cotton by rolling it between your fingers. Ask the patient to look up. Approaching from the side and avoiding the eyelashes, touch the cornea, not the conjunctiva, lightly. Note tearing and blinking. People who use contact lenses will often have diminished or absent corneal reflexes. The facial or seventh cranial nerve innervates all the muscles of facial expression and mediates taste from the anterior tongue. To assess, begin by inspecting the patient's face at rest and during conversation.
Sore in your mouth. How'd you
Note
get it?
any asymmetry, drooping of one side of the mouth, flattening of either nasolabial fold, or sagging of either lower eyelid.
No.
Does it bother you?
Also look for any tics or other abnormal or extraneous movements.
No.
This patient has a somewhat asymmetrical mouth at rest. Next, ask the patient to raise his eyebrows,
Reel up more. Good. All right.
then
Close
to
your
close
eyes.
his eyes so tightly you cannot open them.
Good. Open your eyes.
Next,
Show me
to
your
show
teeth.
his teeth,
Give me a
smile,
Big smile. Good. Now, can you wiggle?
purse his lips,
Okay, good. Now, can you
puff
breathe?
out his cheeks.
Like that, real hard. Don't let me...
Normally, these maneuvers are done
Relax.
easily and
That's
symmetrically.
fine.
The acoustic or eighth cranial nerve mediates hearing and balance. Assess auditory acuity.
Test your hearing, okay?
Occlude one of the patient's ears with your finger
Repeat after
and
what
test
I
the
said.
open ear by softly whispering numbers from 1 or 2 feet away.
45.
Cover your mouth to prevent lip reading.
Good.
Gradually increase your voice volume until the patient can identify the spoken numbers. If hearing is diminished, test for lateralization. Place the base of a vibrating tuning fork
I'm gonna
firmly
test
on the
something. I
patient's
want you
head.
to tell me where
Ask whether it is heard on one or both sides.
Both ears.
The sound is normally heard midline or is perceived equally on both sides. Compare
Tell me when
bone
you
and
stop
air
hearing.
conduction with a lightly vibrating fork on the mastoid process. When the patient no longer hears the sound, quickly place the vibrating fork near the ear canal. This test is known as the René test. Remember to test both ears. Normally, the patient can hear the sound longer through air than through bone.
Now.
The glossopharyngeal and vagus nerves, cranial nerves 9 and 10, mediate the sensory and motor functions of the palate, pharynx, and larynx. Ask the patient to yawn as you observe the palate, which should rise promptly and symmetrically. The uvula should be midline. Then stimulate the posterior pharynx to elicit the gag reflex. You should see a prompt rise of the palate, constriction of the pharyngeal musculature, and signs of gagging. Ask the patient to swallow. It should be done without difficulty or regurgitation.
Can you swallow
If
for
the
me?
patient complained of hoarseness or voice change, you would inspect the vocal cords with a mirror. The spinal accessory, or 11th cranial nerve, innervates the sternocleidomastoid and the upper trapezius muscles. Evaluate the strength and contraction of the trapezius muscles as the patient shrugs his shoulders upward against your hand.
Now hold it there. Don't
Use force compatible with the strength of your patient.
Good. Can you turn your head?
Ask the patient to turn his head to each side against your hand.
Good. Try again.
Observe the contraction of the opposite sternocleidomastoid muscle and note the force of resistance against your hand.
Come up straight up. That's good.
The hypoglossal, or 12th cranial nerve, innervates the tongue. Inspect the patient's tongue as it lies on the floor of the mouth. Observe for fasciculations. There should be none. Ask the patient to stick out his tongue. Note any asymmetry, deviation, or atrophy. The tongue should protrude straight out. The sensory system includes the sensory receptors and nerves, the sensory tracts, the thalamus, the sensory strip, and the rest of the parietal lobe. The body may be mapped into dermatomes. These are skin bands innervated by sensory nerve roots that come from different levels of the spinal cord. Begin the sensory examination of the limbs and trunk by assessing pain with a safety pin.
Yes, would you close your
Ask
eyes
the
and
patient
tell
to
me
close his
what
eyes.
pain is? Whether it's
Start with
sharp
the arms, first testing symmetrical areas. Then compare distal and proximal areas.
Sharp. Dull. Sharp.
Follow with the anterior trunk.
Sharp.
If there are any abnormalities, evaluate the posterior trunk.
Sharp. Dull. Sharp.
End with the legs.
Sharp.
Again, begin symmetrically, then compare distal and proximal areas.
Dull.
The patient's eyes must be closed throughout.
Sharp. Sharp.
If pain sensation is abnormal, test response to temperature.
About here?
Sharp.
Here.
Pulsing.
Okay. Next, I'm going to touch your legs.
With
first,
the
David.
patient's eyes closed, ask him to identify hot or cold as you compare symmetrical areas as before.
Hot. Cold.
Okay, keep your eyes closed. Now I'm going to touch.
Assess light touch with a cotton wisp. Ask the patient to close his eyes and to respond by saying now whenever the skin is touched. Check
No.
legs, trunk.
No. 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 No.
And arms.
No.
For accurate evaluation, allow ample time for the patient to respond before touching him again.
No. No. No.
Vibratory sensation is assessed using a lightly vibrating tuning fork. Ask the patient to tell you what is felt and when the sensation stops. Place the vibrating fork firmly over the distal interphalangeal joint of a finger, then stop the vibration. Vibratory sensation is normally intact distally. If it is diminished, check the metacarpophalangeal joint, then the bony prominence of the wrist and elbow. On the lower extremities, start with the big toes. Compare sides.
No.
If
No.
vibration is diminished, check
No.
at the ankle,
No.
patella,
No.
and iliac crest.
No.
Test position sense by holding the big toe by its side. Avoid contact with the other toes. First move it through up and down, identifying each position for the patient. Now, with the patient's eyes closed, move the big toe up and down in an irregular sequence. With each move, ask the patient to identify the direction of motion. Compare with the big toe of the other foot.
First, we're going to test the movement
Test
of
the
finger
upper
now.
extremities using a finger on each hand in a similar fashion.
Down. Down. Down.
Lastly, test discriminative sensations.
Okay, you can open your
All
eyes.
these tests are performed with the patient's eyes closed.
But I want you to close your eyes.
Begin by testing object identification. Place a familiar object in the patient's hand. Ask him to identify it. Repeat the procedure on the other hand using a different object.
Water.
Good. How about now?
There's a key.
Good. Now I'm going to put it in your right hand and you tell me, what is that?
There's a nickel.
Good. How about now?
Symbol identification is tested by drawing a number or letter on the palm. Use a number or letter which you can draw in a single continuous stroke. The symbol should face the patient, not the examiner. Do one palm, then the other. Two-point discrimination is tested by asking whether he has been touched in one or two areas. Touch the skin exactly at the same time with the 2 points, then irregularly with 1 point. Find the minimum distance he can discriminate between 1 and 2 points. On the tips of the fingers, the distance should be 2 to 3 millimeters. If the findings are abnormal, test the arms, trunk, and legs. To test point localization, touch a point on the patient's skin. Ask him to point to the place touched. If there is difficulty, test the trunk and legs. To test extinction, simultaneously stimulate corresponding areas on both sides of the body. Ask the patient to point to the locations. Normally, he should feel both. If there is difficulty, test the trunk and legs. This concludes the neurologic examination.